That's a right bundle branch block. What's the okay, so right bundle branch block, left bundle branch block. The key is V1, 2, and 3. They look nothing alike. What's the clinical difference between a right bundle branch block and a left bundle branch block?
Left is almost always due to ischemic heart disease.
Right, a left is a pathologic event. It can even signal acute injury. A brand new left bundle has to be considered suspiciously as an acute injury event. Right bundle branch block occurs in healthy people maybe 5% of the time. Military recruits, not necessarily pathologic. What do we got there? That's your arm.
Pretty short PR angle, unless that's a shoulder.
Look at the gestalt. Sort of the overall picture.
It's tacky, first off.
Right. It's okay, but it's not only tachy, it's regular tachycardia.
Right.
And it's relatively narrow angle, a narrow complex. Regular tachycardia. What causes a regular tachycardia? What can you immediately eliminate?
Atrial fibrillation. Atrial fibrillation.
Right, it's not atrial fibrillation.
It's could possibly be 2-to-1 block. A flutter 150 is about where that bit would be.
Yes, it could be, and it is. Atrial flutter, 2-to-1 block. Rate, anytime the rate is 130 to 160, you have to really think about atrial flutter with 2-to-1 block, if it's regular. It is not atrial fibrillation if it's regular. It is not atrial flutter if it's irregular, unless you've got 2-to-1, 4-to-1, 2-to-1, 4-to-1 sometimes. But it should be a regular irregularity if it's atrial flutter. Atrial flutter is not irregularly irregular. But that's atrial flutter with 2-to-1 block. And you don't see but one P wave, do you? You don't ever see the last P wave with atrial flutter.
Usually buried somewhere in the T.
Okay. Now they're getting more fun now. Who wants to do that one? How about the other Dr. Glenn?
So it looks like you've got P's with no following QRS complexes. Looks like.
All of them?
No. Yeah, there's a.
There's a
So So some of the Ps are conducted and some are not.
Right,
So what do we call that?
complete.
Nope. Hmm?
It's not Winky Bach, it's,
Second degree AV block, but not Winky block. You're right.
right.
Two, I think Mobis 1 is Winky block. I can never keep it
Okay.
straight. But
Yeah.
that is, that is second degree AV block because, see, there's a P wave that's not conducted. There's a P wave that is conducted. Not conducted, is conducted, not conducted, is conducted. And it's not Winky Bach because every one of those PR intervals is exactly the same across the board, okay? This is not a benign condition though. What's the heart rate here? 30s and 40s, right? So, second degree AV block with a bradycardia, might well lead to syncope or falling what? Dr. Arndt?
Could that possibly be third degree? It seems like those P's are separated in the, it's,
Well, I have pasted out, and I think that this is regular. And I really think that these P's are all
are conducting.
But that's the key to whether it's third degree block or second degree block. Second degree block has at least some of the P waves are conducted. So you have to believe that to call it second degree block. You're probably going to treat them identically. What's driving the rhythm here? Well, let me put it another way. Those QRSs are wide enough that it could be complete heart block. That is, and this could be an idioventricular rhythm. See, something has to be keeping the heart going. And in this case, I'm postulating that it's those alternate conducted P waves. I'll try to show you an example of third degree, what I think is third degree. Here's your example, Dr. Arndt. Everybody see the difference? There is no question that none of those P waves are conducted. P wave, P wave. There's one here somewhere, P wave. Probably in here, P wave. PR interval very short, PR interval longer, PR interval longer. Could be Winky Bach.
Yeah, like,
Yeah.
Could be Winky Bach. Okay. And that's probably what it is once I paste it off rather than complete heart block.
Because it went
They just
long,
have a
'cause it-
line conflict.
If you
Yeah.
look down here, here's the drop line. Very short, short, longer
and the
drop.
drop one, yeah.
So that's Winky Bach. I'm wrong. It's not complete heart block. Everybody see that? Winky Bach, you have expanding PR interval until eventually you drop it completely and start over again.
Don't you typically have a wide QRS with a complete heart block?
No.
No.
If it is being driven by the AV node,
You have a junction
you
with
can
it.
have a narrow complex.
Okay, so it's jumping.
If the AV node has control of the heart, then you can have complete heart block with a rate of 65 and a narrow complex. But you're right, those are narrow complexes. But they could be under AV node control. So what's the disease process there? Hmm?
Supraventricular
Louder.
supraventricular tachycardia. SVT, sir.
It's what?
SVT.
SVE?
SVT.
SVT. Well, yeah, it is. A little bit fast. It's about 100 per minute. But what else? Hypertension is a disease process.